Okay.
Okay, thank you, Mikdad, for that very generous introduction. You're much missed in York, at least amongst us, small group of ethnic minorities who need to work together to common purpose. I mean, problem, of course, is that there are many ethnic minority academics who actually forget where they came from and don't work hard enough to make sure that they leave the door open behind them. That, I think, is one of the problems in international academia and ethnic minority academics. So what I'm going to talk to you about today is infectious diseases, specifically smallpox. But I also want to talk to you about the historical method. And I want to, at the end of this sort of talk, I hope I leave you with an understanding of how important history actually is to what we consider to be global health. So history is not just ancient history. History is not about histories of heroes, and I use the word in considered ways. It's not about a few men, usually white men. It's much more than that. Wherever we look at practice in what we call global health, there is actually history at play. And history is at play as a justification of what is being done right now in global health. Every moment, every step. So, what I want to sort of show you is how history is constantly used, but also constantly misused. There is history as an attempt to make available to us the largest number of voices of actors at all levels of administration. And at the same time, you have history that narrows the number of people who are actually involved in global, international, regional, and national health, simply to justify the continuing dominance of a relatively small group of people. So let me start with the story, in a sort of nutshell, the story of the United Nations and the WHO itself. So, if you Google or Wikipedia, these are very, very important sort of popular sources of history now, and also very dangerous sources of history, because these have also become online archives have also become part of a very specific creations of history. I mean, again, at the end of this discussion, I would like you to realize or take away or debate with me if online archives are just sort of natural happenings like viruses themselves, or are they actually human creation? I would argue they're human creation, and as they are being created to specific purpose by humans, biases are being inserted into these archives to leave you and me with a certain idea about who mattered and who didn't matter. So, formal archives are actually very dangerous, just as I think Wikipedia is another sort of biographical sort of archives that are being created about great men, usually great white men in global health. So, when you look at Wikipedia and you sort of Google United Nations and health, what you come up with are short descriptions about how the UN was formally unveiled in October 1945 in a conference in the United States, where negotiations took place between April and June 1945. And then apparently a UN charter was signed in San Francisco on the 26th of June 1945. And apparently, this is the most important bit, it was signed, this agreement was signed by 50 allied, and I quote, nations. Now, why do I put the term nations in inverted commas? Because it's a problematic term. In 1945, many of the so-called nations that signed the UN Charter were not nations at all. they were colonies. They included supposed nations like India or British India, which was in negotiation to become independent. So why do these histories call these colonies nations? Because after the Second World War, due to the American regime at the time, colonialism, colonies had become dirty words. What was a more acceptable word was nations. And to get legal recognition, to get legal sanction, to get moral authority, a new charter that created the UN needed to use the word nation rather than empire or colony. So this is very important to remember. Sometimes, these basic terminologies remain unchallenged, and because they remain unchallenged, some of these simplified propaganda as history continues. Even as the UN is being formed, colonialism continues. And what the European actors involved in the signing of the UN Charter is trying to do is to make sure that they retain some control over what is happening in parts of their empire that is likely to break away in the near future. This is something you have to keep in mind. Not unrelated to this is a history of the birth of the World Health Organization. So this new agency was proposed at the so-called International Conference on International Organizations in 1945. And again, if you look at Wikipedia or the popular histories, the constitution of the WHO was signed by 61 quote-unquote nations in July 1946 and was formally established on the 7th of April 1948, with the first World Health Assembly being held in July 1948 in Geneva, Switzerland. Again, the term nations is problematic because not all the people who signed the WHO Constitution were nations. They were still empires, and Britain, France, Portugal, basically all the European empires, even America, it had informal empires. I mean, Philippines has always been an informal sort of colonial outpost of the United States, although the United States would often oppose the idea of European imperialism. There's now a lot of good work which I can share with all of you about public statements and private collaboration, US collaboration with US interests. I mean, I think comes out most dramatically in relation to the Congo, where, it's difficult to differentiate between the official sort of anti-colonial discourse of the US regime and the sort of more private, more hidden connections between US colonial, US economic interests and sort of even after the Congo decolonizes, mining and extractive interests in the Congo, which then results in the breakaway region of Katanga, and then you have the Katangan Civil War in which the UN gets involved. These are, histories that are often not studied in complexity. And what I mean by complexity is the need to not just study published reports as a source of history, but also study unpublished files, which then tell you about the debates, the discussions, the disagreements. Often for me, I love studying multiple drafts of reports, because the first draft of the report is usually the longest. I mean, gold dust would be if you get into an archive and get about 4 drafts of a report and then study each of the 4 drafts, then you see the report becoming shorter and shorter and shorter and more polished and more polished and more polished. You then study, this is just basic decolonized historical method. You then see what is being edited out of each draft, and then you try to study why someone thinks something is inconvenient, and you basically then create a history of the silences that are being caused by political pressures behind the scenes before the final draft comes out. So this is something that would not be done. Previous historians would use a very different method. They would start off with biases. They would say, no, who's the most important person? The European and the American. So we will just study the European and American voices. And if the local brown or black voice doesn't have a name, we can't study them because then we can't quote their name. So starting with that bias, starting with that presumption, many of these histories actually erase the foundational contributions of some of the brown and the black voices on the ground. So when you look at these multiple drafts of reports, what you will find is that usually the European and the American voice doesn't get erased, but what does get erased is ground level experience and ground level reporting, because that is increasingly considered unimportant. So it is a way to tell you that global health as we understand it now exists at various levels. Each level is important. I would actually argue that the implementation level, and particularly in relation to vaccination and infectious disease control, is exceptionally important. Evidence exists, but that evidence is erased when some of these official histories are written. So I'm actually arguing to you as a historian who has spent months and months in multiple archives, is that evidence is actually being hidden away by people who want to write narrow, white-centric histories of global health. So it's a methodological issue. What is also fascinating for me, if you want to problematize the birth of the WHO, is how many origin myths exist. Okay, what do I mean by origin myths? Again, if you Wikipedia, you go online, you basically look at some of the basic histories of perhaps often, written in short form by the children or the grandchildren or some of the European actors who were involved in the creations of the WHO, you get two big myths. One big myth is that WHO was basically an expanded version of the United Nations Relief and Rehabilitation Administration, which was founded in 1943 by the Allied side. It was founded in 1943, blended into the UN in 1945, then downsized and closed in 1947. Why does UNRWA get so much attention? It gets so much attention, I argue, because it was dominated by the USA, whose administrators wanted the world to believe that without the UNRWA infrastructure, the WHO would not have been possible. So for them, from very early on, UNRWA is presented as a WHO precursor. The other big myth, of course, and this is a myth that comes mainly from European historians or Eurocentric historians, is that WHO was little more than the League of Nations. Now, the League of Nations was an interwar organization, complex, but the League of Nations was basically a European organization. The United States was quite isolationist in the interwar years, didn't really want to join it, joined it quite late. But the League of Nations had a health section that operated out of Geneva, and some extremely, respected European historians argue the WHO was basically an expanded version of the League of Nations. Why is this boring detail important? This boring detail is important is because these origin myths are intended to make us believe often that not all was bad with empire. The League of Nations was an organization that was deeply connected with European empire, both in Africa and Asia. It's like saying colonialism was not a bad thing in British India because after all, they got the railways. This is the same sort of argument that is happening. That, health interventions were a good thing, had to be a good thing. The League of Nations was working with administration that might have been imperial or colonial, but ultimately health was a good thing. And therefore, WHO is a good thing, and WHO came out of the League of Nations. So the League of Nations couldn't have been that bad. And then the empires that worked with the League of Nations couldn't have been that bad because they were doing good things. In all these discourses, what is not discussed is how health was being done. And what was bad was the targeted nature of health interventions, benefiting some sections of the population more than others. The most dramatic example of this, of course, is some of the work the League of Nations did with malaria in the tea gardens of northern Bengal, colonial Bengal, now West Bengal, in Darjeeling, where malaria research was done. And ultimately, the local tea planters decided it was too expensive to actually implement it universally. So some of the recommendations were implemented for the planters communities, the largely white communities and upper middle class sort of brown communities. But those reforms, those changes were not implemented amongst the workers' quarters. And when you go into those files, and again, the unpublished files, what you find out is that the argument made is that the labor supply is sufficient. And because it's sufficient, we can always change the labor. So it's actually cheaper to just get more and more labor than implement what would be called science-driven science to improve everyone's health. So it is very important to remember that the League of Nations did some work, made some recommendations, but did not necessarily ever make sure that if there was proven science to improve health, it never made sure that everyone gained from such reform. There is a third view of the origins of the WHO, and this is systematically downplayed even by many non-white actors within the WHO right now. WHO was a product, I believe, of decolonization. The negotiations for the World Health Organization started at a time when it was clear that not all empires were going to remain intact after the Second World War. Some amount of decolonization was going to happen. And that's a very complex history, but it was clear to everyone that some countries were going to go independent in Asia and ultimately in Africa. WHO was a result of that. So if we only look at the WHO as being equivalent to what exists in Geneva, then of course, WHO is not much different from the League of Nations. They started off in the same building, some of the same language, some overlap in staff, yes. But if you have a more democratic view of WHO and look at the regional offices and look at why the regional offices are starting and what the pressures are, again, going into the unpublished material, going into the first draft of the official report of the first World Health Assembly, which is not published, which is negotiated, then published, then you get a different view. Then you realize that countries like Egypt, countries like India, countries like Indonesia, which are decolonizing, which are also becoming sort of infused with the idea that you have to assist other nationalist movements all over the world, are playing key roles in the expansion of the WHO. And so as the WHO Southeast Asia Regional Office starts, as the WHO Office for the Eastern Mediterranean starts, initially in Alexandria, which is now in Cairo, you see the power of countries like India and Egypt often working together to create a completely different international health body as compared to the League of Nations. And that is downplayed in official histories of the WHO. It is downplayed often, even under the sort of direction of our first Director General from Africa. And I don't understand why. Because ultimately, the Geneva Nerve Center of the WHO was intended to be a technical advisory small body. And WHO was supposed to exist in the regions where large regional offices were going to work with newly independent countries on a day-to-day basis and strengthen capacity, most strikingly in relation to infectious diseases control. So, it's a very different perspective of the WHO. So we have to question these Eurocentric notions of WHO is what it is in Geneva. It's not, never has been, and I hope never will be. Because if the regions are destroyed and we have to fight, we have to support the fight to keep the regions relevant, then it is more likely that WHO agendas and interests will be captured, because it's more easy for non-state actors to capture what is happening in Geneva than it is for them to capture what is happening in the regions where there is national protection from powerful nations within each regional office of regional interest. So, I watch what is happening currently, the attempts to centralize power with a degree of concern at the same time when non-state actors like the Gates Foundation are becoming way too influential in the workings of the WHO. And they're not the only ones. There are others who are trying to use the Gates playbook to capture different programs within WHO headquarters, and that must be pushed back. And I work with national governments in Asia, and this is a point I make again and again and again, and their diplomats are well aware of this. BRICS governance is well aware of this. And as they should be, they need to watch this very closely, because otherwise you will start having interference at country level by these external sort of non-state actors, usually with a very technological, non-social, non-culturally respectful set of initiatives. Now you might ask, why am I giving you so much boring detail? So if this becomes your backdrop of the complexity of the UN, the complexity of the WHO, the complexity of the interactions between national governments, empires after the Second World War, with this very complex structure that is the WHO, that is when you can, I think, develop a much more complex understanding of smallpox eradication. So smallpox eradication was not just about the WHO headquarters in Geneva collecting a small set of American and European actors who sat and drew epidemiological maps, talked to very bright people at the center, smart people as they're often called, were supposedly critical global health sort of analysts at the moment, with Center for Disease Control officials in Atlanta, then come up with a plan and then give, sort of distill those plans into 3 or 4 pages and give it to every country so that they could then use that plan. And before you know it, the world had got rid of smallpox. Not only is that argument possible, that is actually the official institutional history. That is the official institutional history of the Centers for Disease Control, which I actually argue in a recent publication with a Brazilian co-author and an ex-student of mine, Carlos Campani, that not only is that an artificial history, it's undemocratic history even of the CDC, where the role of African American actors who played exceptionally important roles in setting up agreements with more than 20 African nations or decolonizing colonies and independent states, their contributions are ignored. And it is then reduced to the history of a handful of people who continue to play an important role in global health per se right now. So a constricted history of smallpox eradication continues to empower the roles played by a small number of men in foundations like the Gates Foundation or the Skoll Foundation. And the immoral thing in all this is that these people sit by quietly and let others do this work for them, which suggests to me that they are complicit. Because if they were not complicit, they would have questioned, say, no. You know, in Bangladesh, we work with those 100 people. In India, we work with those 1,000 people. In Pakistan, we work with those 1,000 people. They don't say any of that. The only Indian voice that exists in the CDC, Emory University's Global Health Chronicle Smallpox Eradication online archive is that of Mahendra Datta, very important Indian official. But one of the Indian officials, one of the few Indian officials who was in deep agreement with US CDC officials and often had sort of worked very closely with them. But there were hundreds of other Indian officials who played as important roles as Mahendra Datta, but did not necessarily agree with everything US CDC officials or WHO officials who were coming in from Geneva were saying. They were actually pushing back, they were helping adapt, and I would argue they were teaching these CDC officials and these WHO officials who would swan in and swan out, you know, 1 month, stay in the Ashoka Hotel and then leave. Yes, travel widely, but travel always with Indian epidemiologists and vaccinators and learn a lot about what was happening at ground level healthcare, but never formally acknowledge in the post-eradication histories about the depth of their learning on the ground. So what I would say is that with a simplistic history of the WHO, simplistic history of the UN, comes a simplistic top-down history of smallpox eradication, which we must question. So I would call this a transfer of ideas thesis. That smallpox eradication was a result of a transfer of ideas from a small number of American and European actors who were to use what is currently a laughable term, but also a term that evokes anger amongst people like Migdal and me, a sort of thesis that followed the science, like our UK government would like to say. And so it was a scientific basis, and apparently that science was only developed in Atlanta and some European centers of excellence. Britain, of course, it was the Anglo-American Alliance, the Lister Institute was always presented as being very important in all of this. True, to an extent. I'm not saying these are not important. What I'm saying is there were many other important nodal centers. So what I like to talk about is history of something as important, as complex as smallpox eradication, as being a puzzle, a 1,000-piece puzzle, okay? And I would go ahead and say that the CDC and the Lister Institute and, you know, the sort of other reference laboratories dotted across Europe were only one piece in that complex puzzle. The other pieces were the nations, their scientific infrastructures, their public health personnel, and most importantly, those community workers who worked on the ground on a day-to-day basis, negotiated policies, negotiated introduction of immunization, carried out follow-up checks, made sure people isolated, made sure that contacts were traced, made sure that those people who are being isolated, often with a guard in front of their house, were never short of food, who made sure that isolation was humane, those people were also members of that 1,000-word puzzle. They often didn't write their reports in English. They often wrote the reports, weekly reports, in a multiplicity of languages. The richness of that material is enormous. That gives you the day-to-day pulse of what is happening in smallpox eradication. What happens then in a country like India? Those reports are then translated by government translators for WHO officials in the Southeast Asia Regional Office. As that translation is happening, certain bits of information disappear because the Indian government doesn't want certain bits of information to go out. Certain bits of information stay. WHO people then get the English translation. Again, there are bits that the WHO doesn't want the world to know. So as they pass on that précis, that translation for briefing purposes, the translation gets changed again, and what I call lost in translation in my classes. So, working back with people who can speak languages, looking at those silences, actually not only tell you, those rich initial reports not only tell you about the richness of smallpox eradication on the ground, but more importantly for me, those silences, those lost in translation bit, tell you a lot about the politics of silencing of certain information and why that was happening by certain agencies. And for me, at the ultimate level, when this primary material is actually being used to create sort of institutional explanations of success, to keep getting money, to keep getting recognition within Western governments, what is very striking for me is the constant refusal to remember the contributions of the many workers at ground level and their importance. So my suggestion, therefore, is to look at the history of infectious disease control through vaccination, immunization, not as a hierarchy, not at different levels, because that creates problems. That creates problems because the moment you have it as a vertical diagram, it is just human to assume that ones at the top are more important than ones at the bottom. And I myself, when I started off doing the research, had this problem, right? I would try to say, okay, different levels, so who's more important? How do you show the importance? So then over time, over many, many years of research, I actually realized it would be more helpful to have a sort of horizontal mosaic, a puzzle, if you want. And that actually allows you to see how all these actors, all of whom are important. I'm not saying the CDC was not important, the US CDC wasn't important, but all these actors who are important are actually linked to each other, supporting each other. And as they're supporting each other, smallpox eradication becomes possible. But, they're not more important than each other. Each one is managing complexities at a different part of the administration, of a complex global administration that comes together to make worldwide smallpox eradication possible. So for me, if you read the two articles whose links I sent to Mikdad, what I'm trying to say with the research I'm doing is that it is very, very important to study every aspect of eradication bottom up. So what are those different bits? One is, of course, the vaccine, something that is in our minds with COVID right now. if you read the official CDC histories, you would be forgiven for thinking there was only one or two kinds of vaccine in circulation, the one produced in the USSR and the one produced in America. You know, it is often presented as this great Cold War history where smallpox eradication creates bridges between two warring nations, two Cold War nations. Partially correct. Some Americans and some Soviet officials worked closely together, others did not. But you know, it's a cozy, warm history that had its political uses in its time, just after eradication. There were many more vaccines. One of the striking things is that I think everyone agrees that the big technological shift that allowed smallpox eradication was the creation of a so-called freeze-dried vaccine, which didn't need constant refrigeration, which meant it could go into the field in countries like India, Pakistan, and Bangladesh, just being carefully stored away from the direct sunlight, but not requiring fridges, which was very important because a lot of villages in the 1960s and 70s were not electrified. Okay? So the freeze-dried vaccine is very important, but what is very striking is that what has now become Bangladesh was East Pakistan, West Pakistan, India. They all negotiated deals with either the US or the USSR, often playing each other, the Soviet Union and America against each other, often managed to get the transfer of technology and develop factories that would produce their own freeze-dried vaccine. And these vaccines became very, very important to the smallpox eradication program in these contexts, because there was also nationalistic pride that India and Pakistan had its own virus. It had its, of course, they had their own virus as well, but they had their own sort of vaccine. Often the underpinning message by vaccinators was that, yes, you know, you can have access to the American vaccine, you can have access to the Russian vaccine, but why don't you have the national vaccine? And often, you know, this messaging was very, very important on the ground. So you have the vaccine. You then have the idea of contact tracing and ring vaccination. Now, the official CDC view is that when CDC started work, how much more time do I have, Mikdav? 10 minutes, 5 minutes?
You carry on as long as you need, maybe another 15, 20 minutes.
Okay. Yeah. So the official CDC view on this is that there was no sort of strategy of containment and ring vaccination before CDC went into the US CDC went into Western and Central Africa and started work in the 20-odd countries funded by USAID mainly. What is very interesting is it's also a period when French African colonies are sort of decolonizing. So there is an attempt by the US to sort of displace French power in certain parts of Africa. It's very much a foreign policy move as well. But the argument is that the task was enormous and there wasn't enough vaccination. So US CDC officials, and Bill Figge is given a lot of credit for this. Bill Figge is now still remains very influential in the US public health establishment within the Gates Foundation. And apparently he came up with the idea of containment and ring vaccination in response to the ongoing shortages of vaccines. So lack of vaccines made him come up with this idea, which then proved immensely successful, that you didn't have to vaccinate everybody against smallpox. What you could do was to identify outbreaks of smallpox go and then vaccinate all the contacts, known contacts of the people who had contracted smallpox, but also then vaccinate everyone in the village in perhaps 5 to 10 mile radius in a town or a village where smallpox cases had been confirmed, and then that, it was said, would break the chain of viral transmission, which would then allow smallpox not to spread. And that was much cheaper in terms of vaccine, in terms of staff time, in terms of, as we now know, generalized lockdown. It was generally much more efficient, it was argued, than mass vaccination come lockdown, till the infection went away. And it was a dreadful, dreadful disease. I would argue, and the archives tell us, that West Africa was not the only context in which these experiments were going on. Indeed, I would argue that in a Cold War context, it was actually extremely difficult to get a country like India to accept a set of ideas that a bunch of Americans working in Africa claimed was successful. It was extremely difficult in a Cold War context to get the Indian political establishment to accept ideas on that basis. So, I started talking to other more democratic members, American and European members of the smallpox eradication program, to try and understand how containment, surveillance containment, and ring vaccination spread in India. Now, the official CDC narrative is it spread from the work of CDC officials in Africa. But as I started working backwards with the help of some absolutely central figures in smallpox eradication, including Donald A. Henderson, and he started giving me information, telling me where to look. When I started looking, what was fascinating was that even as the American CDC, US CDC officials were arriving in Western Africa, the WHO was actually funding containment surveillance experiments across Asia in collaboration with regional offices. So India, or certain Indian officials, accept in the late 1960s the idea of containment surveillance and ring vaccination because of the success of certain pilot projects that have already been carried out in India. So that it is a transfer of knowledge, transfer of science thesis, but where that science is being transferred from is also very important. It wasn't coming from Western Africa and US CDC. It was homegrown science, if one wants to call that, which made it acceptable. So these are these enduring myths that need to be questioned. Why do they need to be questioned? Because these myths continue. When Ebola started in Africa, in Western Africa, or recently, whenever there's reference to containment surveillance, there's reference to the US version, the US CDC version of how it was used in smallpox eradication, how it was transferred, how that transference of knowledge was useful, why that transfer of knowledge suggested that countries suffering from Ebola should just listen to US CDC formulations about how to control infectious disease. It was a history that was suggesting, encouraging dependence. If we then had a counter history at that point and say, hang on, there were countries in Asia and Africa that did their own pilot programs and came out with their own different form of containment, surveillance, ring vaccination, that would have then damaged that narrative of aid giving, of dependence, and would have been pushed back. So again, as I started off, I want to highlight to you how these constricted, narrow histories of smallpox eradication are constantly at play to tell us that we must remain dependent. We must not think for ourselves, that there is nothing worth celebrating in the histories of countries and regions, that it's all centralized and it's all top down. And what I'm arguing to you is it's not. If you go back into the recent past, that is, the post-Second World War era, and start looking in democratic ways about why infectious disease control programs worked in different countries and regions, you can uncover huge amounts of material of local adaptation, local innovation, subnational innovation, that then feeds into regional work. So not only are these localized histories important for countries themselves, they're important for regions, and because they're important for regions, they're also internationally important. We are conditioned to think that international health is health when either Western European countries or the United States is involved. It's not. What does international mean? Collaboration between nations. So when India, Pakistan, and Bangladesh collaborated to make sure that South Asian smallpox eradication programs were based on collaboration, often, there were ceasefire immunization programs where people stopped fighting so the immunization could continue. That was international as well. So that is why the decolonization of history, the decolonization of global health, the decolonization of international health is so important. What is the difference here then between international health and global health? The term global health itself, as used by some people, as used currently in many publications, is a political construct. Now, as impertinent historians like myself and other policy active thinkers start pointing out that international doesn't have to involve high-income countries. International can be a collaboration between a number of low and middle income countries, and they themselves can bring together locally relevant success on the basis of locally available technologies and innovations that must then be recorded. And those innovations are important locally because they don't require for dependence on high-income countries, and then they become threatening to certain Western interests. It is those threatened Western interests then come up with the notion of the global in global health, because the idea of global health as a simplistically used by Western writers and thinkers is one that is telling us that no important innovation in health is possible without the involvement of high-income countries or the West. The term global health, as used simplistically right now within WHO, pushed by non-state actors, is an idea that dependence is not only wanted but necessary. That internationalism is ultimately useless because the science is not there, and the source of the science has to come from a small set of high-income countries. Now, this is where I'm getting increasingly worried about the Office of the Chief Scientist in the WHO headquarters, because the science seems always to come from Northern America or Western Europe. The chief scientist in the WHO headquarters at the moment, an Indian official, seems not to be even aware of the diversity of good science being done in Asia and Africa. And that is not the role of the WHO. The role of the WHO is to recognize the diversity of excellence across each of its regions and bringing people together into conversation, not to create new relationships of dominance and dependence. And of course, this is why more democratic histories of smallpox eradication become inconvenient, because this year, 2020, is the year of the 40th anniversary of smallpox eradication, where only certain aspects of that history are celebrated to justify a certain set of relationships in what is now being pushed as global health. I'd like to end with a reminder that the big red history of the red history of smallpox eradication, published by the WHO in 1988, is a fascinating document. Although smallpox was eradicated in 1980, it only came out in 1988. I was very, very fortunate to see multiple drafts of that book. I would say I've seen 3 drafts of that book. What is fascinating is that if you pick out different chapters dealing with different nations, some are more edited than others. So it suggests to me that some countries had more negotiation power than others. You know, so we must also remember, be aware of power dynamics. You know, small, newly decolonized Francophone country had less negotiating power than, let's say, the Republic of India. Ultimately, what was published about India was only half the size of what was originally written. I find that fascinating. The other article, you know, I sent a link to you about was the history of India's involvement and WHO involvement in smallpox eradication in Bhutan. What was fascinating to me was that India played a very important role in the editing of the history of what happened in Bhutan in that big red book, which then suggested to me that, you know, Bhutan itself or the Bhutanese government's voices were being downplayed in that process of editing, which again showed you the asymmetries of power in international health that are often ignored. Okay, so that red book is fascinating. That red book came out in 1988. 1988 is a very important year. Why is it important? It's the year the polio eradication campaign was formally started. Okay, it was formally started, announced in the World Health Assembly in 1988. It is not an accident that that big red book and the history it presented was required in 1988. So you see, even the timing of institutional histories are often explained. Then when you look at the narrative of polio eradication, the campaign to then eradicate polio is built on the back of an artificial history of smallpox eradication, about how things can be done, how the top-down transference of ideas and technology can eliminate another disease. And I would argue to end that the reason we see the polio eradication initiative over budget, still not complete, you know, decades too late, because we, even though the definition of what polio eradication means, the goalpost has been made bigger and bigger and bigger, it's still not over. I would argue that the reason, one of the reasons that the polio eradication initiative has been unsuccessful is because the logic for it, the justification for it was built on an artificial history of smallpox eradication, which downplayed the importance of national and subnational knowledge and emphasized the importance of the top-down imposition of ideas. The polio eradication program was ultimately successful in some countries like India, because just as in smallpox, ultimately, the small groups of American and European actors realized that, they couldn't push down. India was just too complex. So they then had to adapt policy state by state. They had to listen to very important local workers. Those local workers then taught them what the legal, administrative, social, cultural frameworks were within each state, how religion mattered, how faith mattered, how caste mattered, how these had to be adapted to if there had to be a mass immunization program. Ultimately, lessons from the ground taught the polio eradicators a lot of lessons. And that is where, those are the countries where polio was ultimately eliminated. It's still not eradicated globally. I mean, now, I think the narratives about Pakistan and Afghanistan are unacceptable at certain levels because it's being blamed just on terrorism. It's not just about terrorism, it's about a question of trust. So anyway, so I think that's the best, this is the best point at which to stop and then take questions and have discussions. I'm not quite sure this is what you wanted, Mikdad, but this is more about how histories are used. I thought the 2 articles I sent you had a lot of detail, technical detail about smallpox eradication negotiations and stuff. So there's more about method and its links to policy.
Perfect. Thank you so much. That's been really fascinating. There's already a large number of questions in the chat, but maybe if people can ask them, it's going to make it easier to navigate. Do you want to handle questions as people?
No, go ahead. You handle it.
Yeah. Okay. So if people can just either raise your hand or just ask, actually, I think we're small enough a group to be able to just take questions as they come. Yeah.
Sanjoy, I am quite intrigued by this, the developments at WHO, yeah? So if the US takes a backseat, which is not a bad thing itself, but will then Chinese and philanthrocapitalist funding take over, which should be another battle for countries like India and so on, right?
Okay, so you see, my attitude about the threat of US withdrawal, I'm not too fussed because the US hasn't paid its dues for a very long time. When we talk about US contributions, we often forget the fact that that US support is for specific programs. And when they provide support for specific programs, they also tend to make sure there's US dominance in the management of those programs. So how the accounting is done, and this is, I'm very aware, I'm speaking in the presence of a health economist, so I've never had the tools to expose this, but Mikdad does have these. If you start looking at what is being funded, who it is employing, who is managing, where the audits are being sent to, this is not just the WHO being funded. This is basically groups of US officials running programs globally under the WHO label being funded by the US government. And the howls of discontent that you're hearing, I would argue, is from those interest groups who now feel that suddenly their power will disappear. So I don't want to sound as if I'm agreeing with Trump, but I think those who are advising Trump are aware that there are interest groups that have been running kingdoms or queendoms for a very long time with targeted US funding. And so for me, if the US does leave, this would be a wonderful, wonderful time to reform the organization and say that no, we want US back maybe in 5 years under a new president, or 6 years under a new president. But when the US comes back, they have to give money to the WHO like every other country, and the World Health Assembly then decides how that money is used. Because I am not convinced that all US funding is used with full oversight of the World Health Organization. And that is where we need to follow these money flows. We need to see who's managing the money. Because a lot of this US money is actually for special programs. And of course, all other countries also support special programs. But just like the Gates Foundation, you pointed out philanthropy, capitalism, I think that is another danger. I actually think that is a danger at headquarters level, more at regional and country level. Yes, they give a lot of money, but they don't give money for everything. They only give money for the things that interest them, like polio eradication. So my only hope is all these people who have convinced themselves they have endless power and they can control everything by capturing the imaginations of 10 people at the top will ultimately fail on the ground, because on the ground, the dynamics, the logics, the complexities are different.
So just to follow up quickly and then leave it to other people, there's also need to look at the activities of WTO, because the patent regime, which is controlled by the WTO, is very closely allied to US interests and WHO, because obviously patent revenues or service revenues, as we say, is one of the biggest thing. Now, I don't know if Mikdad or you have done any work on this dual tie-up, and that's where you will find some interesting leads as to how US policy goes, Yeah,
I agree, and I haven't done that, but that needs to be done. And also, I do believe that it'll be another fascinating place to look at combined BRICS action in order to, in efforts, this is, of course, pre-Bolsonaro, but, I mean, there was a Brazilian head of the WTO who was quite closely politically linked to Dilma Rousseff.
Ruben something,
Yeah, but he was a very pro-BRICS person.
Yeah.
So, under him, what was very striking was how BRICS worked together, and that alliance is now shredding because of Bolsonaro. And of course, now I'm hoping very much that the Nigerian lady, her name has been proposed, right?
Yes. This ex-finance minister of Nigeria.
That's right. Yeah, because she knows the World Bank inside out. So if someone who can unpick the World Bank, it's her.
Even Amina is better, the Kenyan one.
Okay. I don't know anything about it.
Yeah, she's much more with it.
Okay.
And she can do something. But you see, unfortunately, at the moment we've lost Brazil. Now, Brazil and India were two of the biggest resistance in WTO, definitely. Maybe WHO. India, I don't know under the present regime whether it's interested in that kind of thing so much, or it's distracted by its own problems at home. Yeah. But if that goes, then the whole of the global South has a problem in these institutions.
I agree with you. And we have to see how this pans out now. If multilateral governance at every level is destroyed, what is replaced? Because, I also think there's an attempt by the other side to capture a reformed form of multilateral governance. So, I think Mikdad has heard me say this in my office whenever we have chats or in Chittaranjan Park often, that in my day-to-day life, fighting the outright racists is actually much easier, because the outright racist, you can challenge them, you can show the narrowness of their views. What has been much more difficult professionally and personally for me has been fighting the very sophisticated racism of liberals. So, again, this is going to be controversial, but I think, opposing Trump and his like is actually easier because they're out there, you can see the hate, you can see their keenness to create damage, you can create alliances against such overt hate. I think what is much more dangerous is liberal presumptions of superiority. And believe me, those notions of superiority, those notions of scientific civilization are underpinned by racism. And the biggest trap that awaits the regimes of India and Brazil under the current dispensation is to blindly accept those ideas of the superiority of that liberal science, because that liberal science is not innocent. That liberal science is consciously trying to destroy other capacities. I think a very good example of this would be what happened with PEPFAR, ARVs, and AIDS. So, you know, American assistance for the PEPFAR campaign, and starting from George Bush, is sort of, you know, a lot of whistleblowers came out, and some of them are very influential academics right now who talk very openly about it. Was not just done because, if we are to believe them, that American ARVs were higher quality than the generic ARVs, but because the generic ARVs that were being championed by South Africa, Brazil, and India were a great threat to American pharma and American economic interests. So through PEPFAR, to flood Africa with ARV as aid was also to make the generic competition less competitive and weaken that competition. I mean, of course, what then happens is the BRICS unites, South Africa, Brazil, India unite, and then gets WHO to say it's fine to use generic ARVs. So yes, I agree with you, because the WTO becomes a very important part in such action. So it'll be fascinating to see what new alliances continue. I think, you know, I think China will make a move for leadership, and China has a lot of political support across Asia and Africa. It'll be interesting to see if the opposition to such efforts at dominance is multi-sided, meaning, is there going to be another sort of Asia-Africa alliance, not reliant on Western Europe and America, that then comes up? And my feeling is that there may be. Maybe India will try to play a role using the Commonwealth Organization. So I think, you know, we'll see multi-sided power centers again, and each power center claiming superiority without any one of them having complete control or superiority. So my hope for democracy is always at ground level, implementation level. Whatever these actors are playing, you know, when these elephants are fighting, not all the ants die on the ground. Some of these ants remain very powerful. So I think my hope lies in those ants. And I'm one of those ants. Yeah.
Great. Peter, do you want to say something? You've had a lot of interesting comments in the chat. And then while you're asking, maybe I'll ask Aisha to maybe think about responding about the WTO and WHO, because I know she's been doing a lot of work on that for the last few years. So yeah, and then Mariamante, if you want to say something about the view from Africa. I know you've had some comments on that as well, and that would be interesting, and also on this woman who may take over at the WHO.
So thank you for a very interesting webinar. Yeah, it's just a quick comment from Cape Town that we're seeing now the countries running blind with COVID-19 because of the shortage of tests, which is basically because tests are single supplier items. We're relying on various patented and proprietary bits and bobs that you can only get from northern countries.
Yeah.
And I mean, this is where I think had Brazil and India and BRICS in general been operating more effectively, we could see an international program, an international campaign that linking possibilities of third-party manufacturing with fighting the patent regimes, playing, I think, a really important role. I mean, in the Netherlands, the Dutch managed to force Roche to hand over key recipes, but I believe that was only for the Netherlands. We are, yeah, and I mean, and this is where international cooperation is important, because on the one hand, we don't have the manufacturing capacity in many African states to do the manufacturing necessary for these components. And then secondly, when international cooperation is reduced to cooperation between presidents and prime ministers, then we see the limitations of that as well, I think, in the current period.
Yeah. No, I agree with you, Peter. I mean, the first thing, of course, is, I mean, it's not unconnected to what Iqbal was saying, that what we see is a weakening of the BRICS alliance. So, I mean, what has happened in COVID in relation to test manufacture is a very, I think, from my perspective, a dramatic description of the results of that breakdown of the BRICS alliance. I think, you know, in each, especially in Brazil and India, what you have seen is the increasing privatization of manufacture and science. Although Fiocruz in Brazil continues to play a very important role, it does so with, I think, 50% of his budget having been cut. So, you know, public science and public manufacture of public goods, which these tests are, have been terribly hampered by political and economic trends in the last 4 or 5 years. But also, you know, if we had to draw on the history of smallpox in relation to the important points you've just made, where did these vaccines come from? Apart from the local manufacture I talked about, the technology transfer I talked about, all the big producers of the vaccine in the smallpox eradication program were well-funded public manufacturers. And what we've seen is a systematic destruction of those public production capabilities through arguments about efficiency that I don't agree with, arguments about quality that I don't agree with. So what are we being told constantly? We're being told that CEPI is going to give us the vaccine, that it's a public-private partnership. But history shows us that public-private partnerships do not necessarily work very well, because ultimately they're not publicly responsible. So what is publicly responsible are these public vaccine production units, or in this case, as you refer to, public production of COVID tests. I mean, the infrastructure has been broken down, the infrastructure has been weakened, and therefore the response doesn't exist. I mean, little known fact is that Indian private companies, very successful Indian private companies, have gone and taken over some of the European vaccine production units and the vaccine pharma production units. So, you know, the Danish and the Dutch sort of institutes that used to produce pharma or vaccines are now owned by an Indian private company, which hasn't changed the name, but now owns them. So and then they produce stuff that they think is profitable, not what is needed for the public good. So yes, I agree with you. I think one of the problems we've had is BRICS, which for me was like a latter-day non-aligned movement, a third force, the weakening of that. Then increasing privatization of production and research facilities in in countries that could have produced these tests in large numbers, but also the privatization of vaccine and other pharma and other medical products in Scandinavia. One of the, smallpox eradication would not have been possible without very, very deep levels of financial support from Sweden, but it's ignored in these US and Western sort of UK-centric histories of smallpox eradication, especially US-centric histories of smallpox eradication. The Scandinavians did much more. The Scandinavians in the 60s, 70s, and the early 80s transferred technology. So, so if we had to draw on this history, I look back teary-eyed at what happened in the 1970s. And if there had been an effective test for COVID in that era, in that sort of situation in the Scandinavian countries, I think that Scandinavia, that internationally responsible, publicly oriented Scandinavia would have quickly transferred the technology to low and middle income countries, which would then have worked with Scandinavian scientists and producers to then mass produce such technology. But, we now live in an era where we are constantly being told that the private sector is more effective. And if something has been exposed by this COVID crisis for me, is that with all the lives that have been lost and with all the sort of limited testing facility we have, and this is especially relevant for the UK, is that the private sector is not responsive. The private sector is not necessarily more effective. And what we need to go back to is very well publicly funded public health, which also includes testing kit production and vaccine production. We don't necessarily need public-private partnership. We need international collaboration. I'm not saying that nations should not, in fact, nations should exchange working technology, but that production has to be publicly funded so that it can be responsive to a diversity of public needs, rather than the needs of, to come back to Iqbal's point, the needs imposed by certain charities and non-state actors on the WHO and countries. Does that answer some of the things, or does that chime with you, Peter?
Yes, very much so. It's a start, and I think that, I'm working in academic setting myself, but as academics and activists, we are playing catch up in a way that we perhaps should not have been playing catch up. We meant to have been ready to go in January, not June, in terms of what needs to be done. But now is better than never. So I think this is the thing that we need to be shouting from the hilltops, that the public production, public health. And one last thing that I would like to suggest is, you talked about the local expertise. In my city, the geospatial technology, which is making good money for companies like Esri. I don't know how much Esri is being paid for the famous Johns Hopkins dashboard. But yeah, so Esri is making good money out of this thing, but the geospatial information is simply wrong in many areas where people live. And I'm sure you see this in India as well, that the name that is used for a place by the people who live there is not the same name as the geospatial experts are using in their map. So then when people write down, when they go to a clinic, I come from this area, then when it comes to the trying to identify areas of transmission and things like that, it just doesn't work, because you've actually cut out the so-called professors of the street that are meant to be the community health workers whose knowledge production is meant to be integrated within the knowledge production system, but it is not.
Yeah, I completely agree. And, in relation to Africa, I really feel that, the Africa CDC has to become more independent. I think it is independent, but it has to become even more independent. I think the Organization of African Unity has to play a more regionally important role, a continentally important role, I think. Of course, there'll be pushback. There will be people in these organizations whose minds are colonized, for want of a better word, who have loyalties that go beyond the continent. But I hope the COVID-19 crisis shows African activists, shows African governments that if they work together, they come together as a collective, just like the European Union, they will be stronger and in a stronger place then to negotiate technology transfers, how work is done in Africa, the recognition of local social, economic, administrative, and cultural practices, and force any external worker who comes in or any external agency come in to recognize this important. I must, it's often forgotten, sometimes I get into arguments with fellow activists because I think they tend to think that the body like the Gates Foundation is powerful everywhere. I would point towards what is happening in India to show that they are less powerful in India than perhaps they are in other places. What do I mean by this? When Prime Minister Modi came to power, he started going at external agencies and limiting their power. And ultimately, what has been very striking is the so-called, what I would like to call the Indianization of the Gates office in India, where top to bottom, the management structures are now Indian. And that was imposed. So I think Gates had a choice. Either they were going to lose all influence in India or they had to Indianize, so they Indianized. And when you look at where the Gates office is active, it's actually active in New Delhi in terms of talking to the central government of India, but actually only active in certain states. Uttar Pradesh, for example. It's not active all over in India. So this is also a model. I'm not saying Modi's administration is a model to be followed. In fact, there are things about it I worry about greatly. I think Mikdad will know that where my political loyalties and I believe faith is very important. I also believe faith is very personal, but I believe faith should be used to bring people together than to divide people. So let me be very clear. But what the Modi administration has shown us, has given us a model for, is how to control the power of these charitable non-state actors within national territories. And I think all governments would do very well to constrict the influence. And then, of course, some governments can do it more easily. I mean, it's fascinating, I find, how much advocacy there is from within the Gates Foundation of Rwanda, which is a dictatorship. So, Gates has to decide at some point, does it support democracies and work democratically in democratic settings? Or does it go around supporting dictatorial regimes and then pointing to dictatorial regimes and lessons that other low and middle income countries need to learn from? I mean, are they so blind as to recognize that democracies cannot work, working democracies cannot work the way Rwanda works? So, I think nations need to be more confident, governments need to be more confident, and the politicians need to realize that they will get much more in terms of resources out of these bodies if they confidently push back. Because, if you go with the begging bowl, these guys respect you less. But if you stand up to them, then they treat you as equals, and equals share more. So this is my view. Does that make sense to you, Peter? I do agree with everything you said, by the way.
I think so, but I think there are other people waiting to speak.
Okay.
Yeah, Aisha?
Good to see you, or hear your voice, Peter, by the way.
Hey, thanks so much for that fascinating discussion, Sanjoy. I think it's right up my line of interest, and I'm going to go around searching for your other articles and, and writings. But there's a few questions that I had for you.
Yeah.
A little bit around the Africa CDC.
Yeah.
I just wanted to know, have you come across anything stating or talking about how the Africa CDC, what role it's played in terms of the regional COVID response? And then generally your opinion on how efficient the sort of grouping has been, and what are the sort of strengths and weaknesses around it. That's the first point. The second point has to do with sort of global health governance, right? So we are saying that this is opportunity, an opportunity for more decentralized, locally based sort of groupings to assert themselves. Now, with global health governance, there's a measure of overall coordination and cooperation needed. So how could these locally or regionally based groupings sort of organize in such a way where the power dynamics that was so inherent in WHO's, inherent in the WHO don't replicate themselves, where you get economic powers dominating the conversation and agenda, right? So how do regional bodies cooperate and collaborate? And I think this like extends to global governance even on a political level. How do you guard against those power dynamics? The third question or point is regarding this public knowledge and research. So interestingly, like there's an article that I have that isn't published. I did it like 4 years ago, but I'm pulling it out because it's still as relevant as ever, about this sort of intellectual property and the ring fencing of public knowledge and bringing it under private ownership. And I've been following the case with, I don't know how they pronounce it. Is it Gilead, the company which is currently manufacturing one of the antivirals? And I see that there's AstraZeneca. There were talks that they're trying to sort of buy them over, and this goes back to the monopolies and sort of mergers and acquisitions that big pharma that allows them to exert their market force. So just back to research and development priorities. And a few years ago, I know that the WHO was looking at different funding mechanisms and different strategies to sort of make sure that research agendas weren't skewed. How far along has this gone, and what do you propose in terms of bringing research and development and research priorities back into the public realm? What do you propose? Do you propose then countries scale up manufacturing capacity? Because this seems to be what big pharma is offering, like kind of what Brazil has done. So you keep your research in the public sphere and you scale up regional and local manufacturing capacities. What do you propose the alternate is? And then to about manufacturing capacities, when we look at like a possible vaccine, if ever, or possible treatments, do you think it's, so we know that the world, the trade rules give you this compulsory licensing, which is a sort of a loophole, and countries can get, like you mentioned, these recipes for the drugs from pharmaceuticals and manufacture it locally. What do you believe is the capacity currently of, let's say, countries like India or South Africa to manufacture these purely within the public sector, or does there need to be the sort of private-public collaboration? So those are the 3 points, just in terms of the global governance, Africa CDC, and research and development.
Okay, so thank you very much for that, Ayesha. So as far as Africa CDC is concerned, my knowledge comes from off-the-record discussions with colleagues, collaborators, trusted friends, both in Britain and in Africa. So it's on the basis of, you know, if you think about the historical methods, it's about oral histories. So, but it's off the record. So some oral history is like investigative journalism. Some of it is more sort of innocent oral history, where, you know, there's just interest in someone's biography, and then, you know, and then you just do an open-ended thing. So my discussions about Africa CDC were not open-ended. They were sort of investigative interviews off the records. I can't mention the names, but, you know, I mean, what is very clear is that there is competition between the WHO regional office in Africa and Africa CDC. So it's important, I think, to not see them, I mean, they present themselves publicly as allies, but privately they're not allies. They're fighting for the same space, for influence. So when it comes to global health governance and the Africa CDC, I think both WHO Africa and WHO on one side, WHO headquarters on one side, have its own allies, and Africa CDC have their own political allies, but at the same time, they also have friends in funding organizations, in non-state actor funders. So there's competition within those sectors as well for funds and influence. Also remember that if you look at the narratives historically, again, if you look at critically at the narratives and the language that are used both in WHO Africa and Africa CDC, or indeed any African country CDC, so let's say Nigerian CDC, the language that is used is of the science. Everyone's claiming they have access to the science, but they're actually using very different data sets, very different sciences. So it's also a battle, I think, to demonstrate that one set of science is better than another set of science. So there is fragmentation, there is factionalism, there is competition. So I think my suggestion would be, and there's so much work to be needed, so it can only be a suggestion that whoever studies these organizations and the relations between them and the impact of those relations on the ground needs to study them not just through the friendly, howdy, I love you, publish reports, but through investigative methods that better allows to better understand the competition and whether that competition is good or bad in terms of, is it improving services or is it fragmenting services? Does that make sense for your first point, Ayesha?
Yes, thanks so much.
Yeah, so it's going to be fascinating actually to see what happens post-Brexit as Britain becomes more active in its targeted aid giving in Africa. So, you know, the so-called Prosperity Fund, 3 billion, more than 3 billion in the Foreign Commonwealth Office, how that money then changes the dynamics in relation to Africa CDC, national African CDCs, and the WHO. It'll be fascinating to see if attempts by British government aid agencies to win influence in Africa end up strengthening one side over the other. So I think, you know, from 2021 onwards, that'll be fascinating. They're already active, but it'll be fascinating to see. You then asked me about global health governance and time. Is it time for localized groups, to act in new ways? The more I think about the term global health, I think I've already tried to problematize in my talk what I think about the term global health and how it is being used and how we should beware of the sort of thing that people are attempting to push down our throats in terms of, the goodness of global health. If we are to stick to the terminology of global health, the term global health, I think a very effective way to invert the term and its meanings would be to point out that global health actually is where ideas and policies are implemented. So I think, and I've been as guilty of this as anyone else, is that I think we need to move away from the idea that where it's implemented is the local, and where some of these ideas are debated, i.e. Seattle or Geneva or New York, is the global. So I think we can subvert that idea by actually saying that the global is the implementation site and the local, the parochial, is actually New York, Seattle, or Geneva. Because that then highlights, I think, the more important part of global health. That is the site where implementation takes place, the site where negotiations take place, the site where adaptations take place, and the site where lived reality happens, rather than idealism, politics, civilization. It also, I think, highlights, if we take this approach, it allows us to show that the subnational, which is a term I'm increasingly using rather than local, because the term local is used in very derogatory ways by some of these global health actors as largely uncivilized dark places where they are bringing light through the science, is also where we see the best of faith-based work and collaborations. Other sort of state actors who have for many years played an extremely important role. And again, this is not just about Christian missionaries in Africa very successfully running primary healthcare centers, but multiple faith groups providing healthcare facilities to communities. I mean, Peter's online, in South Africa, in Apartheid South Africa, there were multi-religious missions serving multi-religious communities in a deeply racially divided society in Apartheid South Africa. So yes, I agree with you completely that I think the COVID-19 crisis gives us a time, an opportunity to strongly advocate the importance of the subnational and the national in global health, by pointing out that the national and the subnational are actually the heart of the global. The rest of it is peripheral. But we also have to be politically realistic, I think. I don't think we can do this alone. We have to create alliances. I was horrified recently when I looked at the membership of the COVID-19 Social Science Advisory Expert Group in WHO headquarters, which was supposed to advise the WHO headquarters about the political, economic, and social characteristics of COVID response and, and the determinants that the WHO headquarters needed to be aware of. It's hardly any representation from Asia and Africa there. So how do we work in alliances to break down these attitudes where the attitude is civilizational and the membership is largely North American and Western European, not even Eastern European? I think by working with our connections in government to send emails, to send open public questions to the WHO about why this is still being allowed to happen. What are the hidden funding streams that are giving these advisory bodies their shape? There has to be absolutely clear declarations of interest that are publicly visible to us when such expert groups are made. Because these expert groups which certify the science, when it's offered to governments, have to be as diverse as the membership of the WHO itself. It cannot be at that stage a small group of white men and women who say this is what is the best and all countries of the world have to use it because we as experts have decided that it is socially, culturally, economically, and politically okay to accept this set of recommendations without any understanding of what the lived realities, political, social, economic, or cultural are in diverse Asian and African countries. So, I was asked to comment on one of these papers they were rapid reviewing. What was very striking was it was a call for the mandatory making face mask use mandatory. But because most of these people were from Western Europe and North America, authors and these expert group members, what was very striking was they had no idea about the economic differences, the lived reality of poverty, no idea that face mask use was made mandatory, that a family of, let's say, 6 who are struggling to survive in the economic disaster that is enveloping all of us, that buying of 6 masks would most probably mean no food for such families. So that empathetic lived reality is disappearing because of the sort of cultural dominance of a very narrow group of people over how the WHO is sending out its decisions, recommendations right now. So we have to be realistic. We can't do this just as activists. What we need to do, I think, is create political alliances. We need a lot of people to ask these hard questions of the WHO and non-state funders based in the US or in the UK, so that they feel pressured, because many of them actually have some decent folk in them, but they need to be challenged and questioned so that they can rethink their assumptions. Right now, they're under no pressure to rethink their assumptions because they're surrounded by these yes men and yes women from a very narrow group of countries who, if you look at the grant records, are constantly funded by these bodies. And yet, there is no declaration of interest. So there has to be some critical independence in these expert groups. And this is, I think, the need for alliances across sectors that we as activists, academic activists, can create is going to be crucial. So we can come together, we can pull in all our political connections, we can create, by combining our political and civil society connections, I think a very powerful questioning force, which then has to be deployed to push back against some of these ideas that are going uncontested, but untested in diverse contexts. So does that answer your second question, Aisha?
Yes, thanks so much, for sure. Yeah.
Okay. Now the third question, I think, is about capacity building, public-private partnerships, vaccine production, or general public goods production. I completely agree with you that this is again a moment where we need to push back. We really do. And we need to, if COVID-19 has taught us something, is that the idea of globalism in health is hollow. What do I mean by that? That when there's a crisis like COVID, and there are shortages of vaccine or pharma or masks or whatever, countries close their borders, countries try to look after themselves. And of course, within those countries, certain governments, like our own in the UK, looks after some of us more than others, ongoing debate. So, even within nationalism, these are ethno-nationalisms often, where some lives matter more than others. So perhaps just by exposing that point, that ultimately the ideology of the global is hollow, and in crisis, nationalisms with all the nastiness of ethno-nationalisms often reign. We then need to use this as an entry point, perhaps, to change an idea of the global, where the global perhaps should mean a relatively small number of actors who empower multiple nations to create effective public health production units. And then, if that is done, then give the credit that is due to these global actors. Call them global health heroes. Ultimately, they all want to be called heroes and be remembered in history. Not quite statues, because I think everyone's now realized that statues, I wonder why people are surprised. You have a poem like Ozymandias, but anyway, they don't quite want statues, but they want wonderful histories written about themselves. Fine, let's give them those histories. But if they want to be global actors, they then have to play a role in helping low and middle income countries set up production capacities for various products that are needed in pandemic preparedness, so that there is no dependence at a time of crisis. That is, I think, something Peter was talking about, that the current global health relationship has created a crisis which has highlighted the dependence of the many on the few. And in a time of crisis, the few who are used to playing God and sweeping in, and usually in the white horses, in the shining white armor, have been lacking, because their science, which they keep claiming has answers for everything, was limited, as was their capacity to produce. And therefore, the current crisis has not just caused a lot of innocent life, it has showed up the hollowness of the claim of control that global health has been trying to peddle to us for years. So my understanding is the nation and national production capacity is very important, because we have to wake up to the fact that in acute crises like COVID, nations work on their own. Then the international is very important, because, as Peter pointed out, Roche came out with a more reliable test than others. So international relations then allow nations to exchange such technology. And the global, as defined by non-state actors, has a role to play, perhaps to enable the spread and the entrenchment of effective production processes, especially in low and middle income countries. Public-private partnerships are not necessarily, in my view, the answer to pandemic preparedness, because there is a profit motive. And pandemic preparedness cannot be hostage to any demand for profit. How do you monetize life lost? You can't. So I think I can only hope that every self-respecting national government now returns to the public production of important public goods like vaccines or antivirals, as Ayesha, you pointed out. I'm less sure I've answered your third question, Ayesha, but does that, at least in part, answer what you were asking me?
Yeah, I think definitely, and it's given me even more food for thought. So thank you so much. And you can
So
expect.
so where are you based, Ayesha?
I'm based in Istanbul at the moment,
Okay.
but from South Africa.
Okay.
Yeah, I did my master's through a university in London, so
Okay.
all over the place.
Okay.
Yeah.
Very good. Thank you for your question.
Okay, so Sanjoy, if we have a few more minutes, maybe
Yeah.
we'll take a question from Mariamanti in Nigeria. And then if anybody else has questions while Sanjay responds, then maybe if you can, we'll take a round of comments at the end, and then we can just summarize after that. So if everybody thinks of any final comments they want to make.
I'll also download the questions so that I can think about them and then respond to people in more detail.
Perfect.
Yeah.
Perfect. And if you want a response directly, maybe if you put your email in the chat so that Sandra can then pick up with you.
Yeah, or I'll just trouble Mickey.
Or through me, indeed.
Thank you very much for really very educative expose and discussions. I have 3 comments.
Okay.
The first is around the interrelations between the African CDC and the national CDCs and the WHO. I think a lot has to do with the political position of the country. For example, in Nigeria, the Nigerian government made the Nigerian CDC very strong. So ultimately, the WHO and everybody else listens to the Nigerian CDC.
Yes.
And so even if the global CDC, US CDC says something, then it goes through the Nigerian CDC. But the downside of it is that who's the human being heading that organization? Of course, it's somebody that had worked in this, the US CDC before. So, but if you had somebody else with a different view, then it's going to be quite, so the human being is very important in that case.
Yes.
The second thing that I want to comment has to do with what Iqbal started discussing around the WHO and the tussle for power in the WHO. I think the WHO has not had it in a long time as good for developing countries or for countries from other regions other than Europe and America, in the sense that we have Theodros and we have Amina Mohammed as his boss. And then the SG, again, they're all, if you like, open-minded people. And they're all if you like, Westerners or non-Americans. And the fact that Theodros is an Ethiopian, and Ethiopia has a very strong sense of nationalism, of doing things differently, and so on and so forth. I think there's no better time if the influences that come together to work with Theodros while he's still there, to actually do some of these things that are right. I was just thinking, how much of this history does he know of WHO? The way, the way. So how do we? I was actually thinking to ask permission to see if we could, if we have permission to send this discussion somehow to him to hear, or if there's an abridged version that just talk about this history of the WHO for him to get to know. Because if he does know, he is a kind of activist that will work hard to make sure he changes as much as possible in the dynamics before he leaves. And I don't know how true it was, but here there was a big celebration when he made a comment, when a comment was accredited to him, that he said, ab initio, no testing of COVID vaccine in Africa. Africa is not the place to go and test COVID vaccine.
Yes.
So those are powerful statements. The second is to do with the question that was asked about Ngozi Okonjo-Iweala versus Amina, and the comment around her being a great opportunity for the position that she's being proposed. I'm not so sure. She was she moved from being the Minister of Finance to she was from the World Bank, came to Nigeria as Minister of Finance, but for all the period that she was a Minister of Finance, she was being paid her salary from World Bank, and she was the only one that has ever happened to. And before she left, yes, we had the debt relief and everything, but before she left, we were as in much debt in World Bank as we were when she came. So, and finally, by the time she left the minister to go and be the chairperson of Gavi, she actually approved everything Gavi said. Luckily, I was at Gates Foundation. Then I was head of Gates Foundation in Nigeria, and I saw all the papers, how she just danced to Gavi and forced Nigeria literally to pay back Gavi some amounts. And so there were lots of objections when she turned up immediately about chairmanship. And they were saying, did she give Nigerians 200 million to be chairman? So those are things, it could have been
I
that
didn't know
it was
that.
the right thing to do. She did just the right thing, and Gavi saw that she was such a good person that they approached her. But such things don't happen so easily. And then so I'm not sure about that. And the final comment is about the Gates Foundation. I think we give too much credit to Gates Foundation than it is due. We assume it's as the power we give it. I don't think, as an insider who set up the Nigeria office, who worked for 5 years, who was responsible for negotiations, it's not as big as we give them. And you would see this as a good example in Ethiopia. The Ethiopian government said, look, we want to develop our own primary healthcare system. They developed a blueprint for their primary healthcare system. And they said, everybody who wants to help you have to buy into this. You cannot come and do anything parallel. USAID was the first to leave, but then it came back. And then the Gates Foundation was the first to give them the whole of the grant, 500 million in one check, and say, oh yeah, this is our support, but we'll put up mechanism to monitor you. But in countries like Nigeria, where you have a huge gap in the government does not know exactly what it wants. Those are the places where the Gates Foundation will come and plant whatever it wants, because there's a gap. And in India currently now, the tussle, I suppose the Indian government is now shows that it has what it wants.
Yeah.
But for me, when you're dealing with Gates Foundation, the Gates Foundation as such is not the big issue. The big issue people should be looking at for are the people who feed the Gates Foundation information. Yes, the Gates Foundation in its health the health team, they have some of the best experts in the world, but a lot of the information is given from either pharma companies or companies or organizations that like the Center for Disease, Allergy and Disease, where Fauci heads. Those are the ones, or Gavi. Gavi has tremendous influence on knowledge that is filtered in the Gates Foundation, and Gates Foundation gives it to money. So it's the scientists in those places. And the way Mr. Gates learns is where we need to actually influence. He gets bouts of days where scientists come from everywhere and give him. So if people like you come and give him and he gets that will be the mantra for Gates Foundation. So is the influence, how do you get there to actually educate the leadership of the Gates Foundation? But that they're allowed to do what they do, yes, they do. But if you push back and you push back on science,
yeah,
and especially if you get Mr. Gates, it's an empire of one captain. If he believes in it, everybody else changes the dance tone and just dances to whatever that is.
Yeah.
Thank you.
No, thank you, Myra. I agree. And if I could just quickly give my comments, I mean, absolutely, I've learned a lot, which is the best sort of event to be part of, and I've learned from every one of you who's questioned me. But so yes, I agree about your characterization of the African CDC and have learned about the importance of Afropolitics, and was not aware of the dominance of the Nigerian CDC. So these are things I have to study more. And of course, I mean, the other big CDC, of course, is the China CDC. And in relation to Africa, that is going to become increasingly interesting as China becomes more and more active through aid programs and other things. Again, health is beneficent non-threatening, and I wonder if Chinese CDC actors will become more actively involved in creating links with different national African CDCs. We wait and see. Maybe the connections already exist. If they do and you know about it, please tell us, because that is something I've been thinking about. Second question about Tedros. I don't think even there's no reason Tedros should know it, and there's no reason for me to tell Tedros this, but I was working with people who were supportive of Tedros during his election. And I was doing this by constantly pointing out to them the Eurocentric and the US-centric biases in some of the history that was available. And why was I doing this? Because, of course, the main threat to Tedros's election was Nabarro, who was basing his campaign on a very recent history that was UK-centric and artificial. So, so right through Tedros's election campaign, we were very aware of the power of history, or the rewriting of history, in order for the first African to become the WHO Director General. And my connections here are fascinating, because this is, I used to run the WHO Global Health Histories Project, which is an official WHO activity. And as I went and organized these very inclusive, nationally inclusive, racially inclusive events in WHO headquarters, I made a lot of friends and a lot of enemies. Enemies were usually people saying, oh, where is the speaker from Harvard or Oxford? And the friends were the people who liked the fact that I was bringing in academics and thinkers from all over the world with very generous welcome trust support, which I'm very grateful for. And they put no pressure on me. We were able to, it was really, truly remains a decolonized piece of work. So during the WHO Global Health Histories seminars, I made a lot of low and middle income country allies, friends, allies, and some of these friends and allies were deeply involved in the the Tedros election campaign. And so, interesting, they're the ones who approached me and said, tell us, give us the decolonized history about WHO. And I think they made some use of it in encountering some of the more sort of civilizational histories that were given by the other side about how Great Britain had greatly improved international and global health. Soon after Tedros was elected, these allies who remained close to Tedros suggested I write a 1 or 2 page briefing note about the importance of such histories and the uses, the practical uses of creating living decolonized histories of the WHO, bottom up, region up, so that they could be enmeshed in processes of reform within the WHO. We did it. We actually provided a 1-page version and a 2-page version, and we don't know what happened to it. Now, at the same time, what we noticed was how dramatically the senior management of the WHO was being changed by Tedros. I mean, there's been two stages of reform, as I'm sure you know. But what was very striking to us was how many assistant director generals suddenly came from low and middle income countries, and then there was a further reform. And I think that further reform also came as a bit of a backlash from the high income countries, and there was a bit of a reshuffling. So I agree with you completely, Myro. I think that if Tedros showed an interest in decolonized history, it would strengthen many of his messages. But at the same time, he's an activist, he's a politician, he's been Minister of Health. I think one of the reasons he's been so effective against Trump is because of his political background. You know, he's played an absolute political masterclass in countering Trump. All that is great. But I also think that, you know, a resource-starved WHO, he's also aware that his organization is resource-starved. And I sometimes wonder whether that is causing him to ignore the decolonized, empowering histories of his organization, so as not to lose allies amongst the non-state actors that can provide his organization with the resources he needs. So my sense is that there's been pushback, not necessarily by Tedros himself, but by some of his advisors, against a democratized, decolonized global health histories, simply because it asks too many inconvenient questions about actors in high-income countries. And I don't see that as a weakness. That makes me smile, because at least we are noticed. At least we are scaring people into hiding malpractice where it exists. But yes, you know, it is very interesting is that a Swiss lawyer has been empowered to create the WHO Museum and its new institutional history. He's only working with American and Western European historians who write these idealistic Eurocentric and US-centric histories. So yes, I think, you know, history has a publicity purpose, and maybe the part of WHO that will now create a WHO museum is best served by working with historians who are more publicists than honest historians, or have the historical skills really to look at archives in complex ways and write critical histories. But I do believe that critical history writing has a very important role to empowering people in policy, and especially on the receiving end of policy. So, you know, I was in a WHO expert group meeting yesterday where this was a regional, Europe regional office expert group on cultural context of health. And again, the way culture is defined is as if Europe is a monoculture. But Europe is not a monoculture. Europe is multicultural. So the question I then asked is, those who study migrants and those who study ethnic minorities, are they ethnic minorities or migrants themselves? Or is it people looking in from the outside without language, without any notion of real culture? Because that in itself is, I think, a very, you know, I argued, bad culture to impose your definitions on another culture. They admit it. They don't involve members of ethnic minorities when they study ethnic minorities in Europe. So, you know, I mean, critical history writing, critical humanities, critical social sciences has a very important role to play. Especially in the WHO. I'd be happy for someone to tell Tedros about this, but I would be very nervous about Tedros thinking that any part of my being or future depends on WHO accepting what I do. Because I think my biggest strength is that if tomorrow I walk away from my WHO Global Health Histories project, nothing happens to my career. It might actually improve. It'll allow me even more criticality and more critical space. So I'm worrying currently as I sit here about some aspects about what I'm seeing. If Tedros is an activist and a Democrat and wants to empower low and middle income countries, why is he not making sure that the regions and the low and middle income countries are represented in the expert groups? That's the first step. And if someone can take that message to him, please take the message to him. It doesn't matter whether I'm involved or not. The important thing is that talent, knowledge, expertise exists in low and middle income countries and institutions within them. We cannot allow the peddling of an artificial history that suggests that this expertise does not exist. Histories like that then justify US and UK heavy expert groups, which have a colonial attitude in all matters, political and policy. So, very simple thing Tedros can do is to democratize the membership of every expert group and push back against non-state actors. You know, Gates, Wellcome, they all push for certain people to be put in to the expert review groups. Maybe they can be allowed in, but equally, you need to put others who have the moral spine to question some of the generalizations that are then presented by these very constricted expert review group members and push back. Because right now we have expert review groups who already think the same way. So it's eyewash. It's not doing what it's intended to do. Bring in information from all the parts of the world. Maybe, you know, they should put you, Myro, in some of the expert review groups so that, you know, with your deep knowledge about how politics and funding works, you can challenge some of these simplistic narratives of goodness that we are supposed to just blindly believe. I again agree with your third point about the Gates Foundation. Did not know about the Ethiopian case study. Thank you for teaching me about that. And yes, Gates is very important. The only time I've applied for a Gates Foundation grant was when they, for the first time, I think they launched a call for a group of historians to help them write the history of polio eradication. And we put in quite a critical sort of plan based on quite critical methods, based on the idea that you know, history is a mosaic, they're all interconnected, and we cannot reduce the history of polio eradication to a small number of European and American actors. I mean, unsurprisingly, we didn't get the grant, and the grant went to Johns Hopkins, to very interesting, a very young scholar. So our grant was actually, I was co-I with David Heyman, who I admire very much, who's again an uncompromising, you know, thoughtful, critical global health analyst. And we both agreed in the end that I think we were seen as too difficult to control. What was fascinating, of course, was the team that had been given the money then contacted me later for advice about how to do oral histories, at which point I said, you know, I think you should talk to Seattle about how they want the history done, not me, because, you know, it just didn't make sense for me then to advise the project. But in one of these phone calls that the Gates Foundation organized before the grant application was submitted, a journalist attended one of these phone calls. And she then wrote a very interesting article. I can send any of you who are interested in the link, where, you know, the reference to Africa, I thought, was absolutely shameful. Because in that article, the person of the Gates Foundation was saying, you know, it is very important that we write these histories. And the strategy is very clear. What they said was, we will write these histories, we will then embed them in the curricula of public health schools in the leading universities of the world. And it is very important in one of these quotes, I mean, it's not an exact quote, but this Gates representative was saying that it's as important for the Harvard public health person to know about the African witch doctor and his role in health and how he can help open up vistas, I suppose, for programs like the polio eradication program, as it is for how success was arranged by some of the European and American actors. Now, that is the point when I'm reading this article, I'm thinking, so you're saying that all there is to learn about Africa is the quote-unquote unscientific. So such a history is automatically saying there are no African scientists, there are no African actors. The only African actors are the traditional medicine, traditional medical actors. So it's, you know, it's sad. I'm very happy to have a one-to-one with Mr. Gates if he wants to have a one-to-one. He'll just have to be aware of the fact that I'll speak as I'm speaking to all of you. In that sense, my spine is extremely inflexible. I find it very difficult to bend in front of people. And I'm glad to have such an inflexible spine in that sense. And yes, there's a lot of democratic history to share with him, if only he'll hear. I completely agree with the scientists. I mean, Bill Figge, who has been represented in the history of smallpox eradication as the central figure of smallpox eradication, is, in my view, not that central in smallpox eradication. You speak to hundreds of Indian smallpox managers. Everyone remembers Donald Henderson. Very few actually remember Bill Figge. Because in reality, when you look at the files, he didn't spend that long in India at all. This mythology of him playing an enormous role has been created by admirers who either work with him and have not declared their conflict of interest in that sense. But it's a mythology that has worked very well for him. And Bill Figge has been able to use a very mythological narrative of smallpox eradication very effectively from his position within the Gates Foundation. I've actually encountered him. We invited him at the Wellcome Trust Center for the History of Medicine at University College London to give a speech. He was clearly shocked because he's not, I think, used to people pushing back and asking tough questions as the audience that they did. And it was very clear that his idea of history is history as propaganda rather than history as criticality. And his only criticism he could give us historians who were questioning him that day was, oh, you don't have a certain set of methods that we epidemiologists have. But then I had to point out to him that epidemiology itself has multiple methods. And if it didn't have multiple methods and all epidemiologists thought in the same way, then how would one explain that about, you know, I'm not going to name names, but quite a large number of US CDC officials were actually thrown out of India for not doing their job well. If it was so simple and if it was so objective, how is it that some US CDC officials were not seen to be objective and working in the same way and reinterpreting the rules and therefore asked to leave India? So anyway, does that sort of engage some of your comments, Myra?
Yes, it did. Thank you so much.
Thank you. Thank you for your comments. I'm going to think much more about that the rest of the day.
Okay. Anybody have any final comments? Maybe we take them all together and then we can summarize.